Hello, my name is Daniel Rosen and I'm a pathologist from Baylor College of Medicine and the VA Medical Center in Houston, Texas, and this is the thyroid and parathyroid gland pathology course. The goal of this lecture is for you to learn the basic concepts in thyroid gland and parathyroid pathology. The objectives are in this slide. So in thyroid gland disease we're going to talk about inflammatory processes, goiter, functional abnormalities of the thyroid and neoplasia. First, the granulomatous thyroiditis of the Kerbein thyroiditis has a triphasic clinical course of hyperthyroidism, hypothyroidism, and then return to normal thyroid function. This is a self-limited condition. Patients are most commonly women of the middle age, and they classically show increase of T3 and T4 and decreased TSH and iodine 131 uptake. It is thought to be, and most people agree, that this is cause of a post-viral inflammation illness, but it's not associated with any autoimmune thyroiditis. Grossly, we will see an asymmetrical enlargement of the thyroid. Microscopic characteristics are the presence of focal microabscesses, mixed inflammatory infiltrate with lymphocytes and histiocytes, and non-caseating granulomas with giant cells. High power view, you can see the giant cell with colloid inside and the presence of acute and chronic inflammation. Fibrothyroiditis or reduced thyroiditis is a very rare disease, shows extensive fibrosis of the thyroid gland. Usually goes beyond the thyroid gland into the surrounding tissue, making the diagnosis of cancer one of the differential diagnoses. The microscopic image of this lesion shows extensive fibrosis of the thyroid gland and vasculitis with encasing fibrosis, similar of what we see in the IgG4 disease, and of course the chronic inflammation as shown in this picture. You can see also the residual atrophic thyroid follicles. Autoimmune thyroiditis is composed by lymphocytic thyroiditis, Hashimoto's thyroiditis, and Graves' disease. Lymphocytic thyroiditis has abundant lymphocytic inflammation, Hashimoto thyroiditis also inflammation, and Graves' disease also presents with lymphocytic inflammation, but to a lesser extent compared to lymphocytic thyroiditis and Hashimoto's. The thyroid follicles in lymphocytic thyroiditis are normal intervening follicles. The Hashimoto thyroiditis show follicles that are lined by oncocytic cells, and Graves' disease has hyperplastic intervening follicles. So with these two characteristics of the lymphocytic inflammation and thyroid follicle characteristics, you can pretty much tell them apart. Lymphocytic thyroiditis or painless thyroiditis is caused by antibodies directed against thyroglobulin or other follicular cell antigens. It causes a transient hyperthyroidism, and microscopically you can see the lymphoid aggregates with reactive germinal centers and the residual thyroid gland in the background. So here you have the scattered interstitial lymphoid follicles with germinal centers. Hashimoto thyroiditis, the most common cause of hyperthyroidism in iodine-sufficient areas, more common seen in women than men in a ratio of 20:1, and in patients are around 40 years old at presentation. It is caused by autoantibodies directed against the thyroglobulin, TSH receptors, and other follicular cell antigens, resulting in this follicular damage. There's an increased risk for B-cell lymphomas. Hashimoto thyroiditis produces a diffuse or localized enlargement of the thyroid gland. The capsule is intact and the cut surface is firm. Microscopically, you can see the small residual atrophic thyroid follicles with this scattered intervening lymphocytic inflammatory infiltrate. The follicles are lined by oxyphilic epithelium or Hartle cells which are the cells that show these eosinophilic cytoplasm, and the scattered chronic inflammation in the background. Hard cell hyperplasia is very commonly seen, which is depicted by these oncocytic type cells with the eosinophilic cytoplasm. Graves' disease is produced by antibodies against TSH receptors. There is follicular stimulation and hyperthyroidism, and classically shows increase of T3 and T4, decreased iodine 131 uptake, and decreased TSH. Usually occurs in young adult females around 20 years old, and there's a strong association with HLA-B8 and DR3. Graves' disease gross examination shows a very symmetric enlargement of the thyroid gland, and the cut surface is usually red, and I call it salmon color cut surface. You can also see the nodular architecture of the thyroid gland. Microscopically, it shows the hyperplastic follicles with intact capsule. The surrounding normal thyroid parenchyma, if anything left, is collapsed and pushed to the side. There's many degenerative changes associated with Graves' disease, such as hemorrhage, like you can see here with the hemosiderin-laden macrophages, and usually cystic dilatation. Also, scarring is very common, and it's not uncommon to find papillary projections of the thyroid follicles, especially in patients that receive treatment with PTU. Nodular hyperplasia is the most common thyroid disease. It's due to a low dietary iodine, and the majority of the patients show normal thyroid function. There's usually focal increase of iodine 131 uptake. Some cases are associated with Hashimoto's. There are two types of simple goiter or non-toxic goiter, which the first one is the endemic goiter and the second is the sporadic goiter. The endemic goiter has a very classic pathogenesis. Patients have low iodine, which leads to decreased thyroid hormone synthesis, which in turn turns into an increased TSH and causing the endemic goiter. The sporadic goiter has an unknown etiology, common in young adult females, and there's a slight hormonal impairment. Remember that all simple goiter will eventually turn into multinodular goiter. Grossly, you can see the bosselated appearance of the thyroid with the multiple nodules on the external surface, and the microscopic characteristic of this nodular hyperplasia with fibrous tissue and scarring. There's variable follicular size, and the papillary formation can occur. Benign tumors of thyroid. The follicular adenoma occurs predominantly in young to middle-aged women, presents as a painless solitary nodule, and typically patients are euthyroid. There's little or no iodine 131 uptake. The follicular adenoma is a well circumscribed lesion with a thin capsule and with compression of the surrounding thyroid tissue. The microscopic patterns of follicular adenoma are the normal follicular adenoma, the macrofollicular adenoma or colloid adenoma, the microfollicular adenoma or fetal adenoma, and the trabecular or solid adenoma or embryonal adenoma. The normal follicular adenoma shows the normal size follicles with a complete thin capsule and compression of the surrounding thyroid tissue. The microfollicular pattern shows small follicular proliferations, like you can see in this picture. The solid pattern resembles more of the embryonal type thyroid with small follicular structures and cells that are usually growing in a sheath-like pattern. The hyalinized intravehicular adenoma is a trabecular growth pattern with prominent hyaline material between cells. This lesion resembles a neuroendocrine neoplasm like a paraganglioma or medullary thyrocarcinoma. The nuclei are similar to those seen in the papillary carcinoma, and occasionally you can see samoma bodies. There's also a description of red and PTC rearrangements. It's a benign tumor, but it can be easily confused with malignancy. This growth of these organoid or round structures with cells that have a low NC ratio with ample cytoplasm, and usually a central nucleus, and occasionally intranuclear cytoplasmic inclusions can be seen. These groups of cells are separated by these thin, fibrous bands with delicate vasculature. Hard-to-cell adenoma it's composed by large follicular cells with granular eosinophilic cytoplasm. The cut surface is usually brown, and microscopically shows polygonal cells with round regular nuclei with inconspicuous nucleoli and granular eosinophilic cytoplasm. As you can see in the picture, it has this oncocytic-like appearance with cells with ample pink cytoplasm. There's also residual colloid shown in some areas. Malignant tumors of the thyroid, the most common is the papillary carcinoma. More than 85% of the cases are papillary thyrocarcinomas. It has a slight female predominance, and 25 to 75%, depending on the series, can be multifocal. It tends to spread via lymphatic route, and this is very important for you to remember, lymphatic route. And 33% of these tumors have lymph node metastases at presentation. Grossly shows variable size nodules, solid or cystic, and can infiltrate the capsule or can be encapsulated. Also, these lesions can be solitary or multicentric in about 20% of the cases. Microscopically, it shows the classic characteristic of papillary formations. Cells have ground glass nuclei with nuclear groups, and also it's common to see nuclear pseudoinclusions and samoma bodies. There are many variants of papillary thyrocarcinoma as shown in this picture. We're going just to describe the most common ones. The conventional type of papillary thyrocarcinoma can show focal areas of calcification and a papillary growth pattern. High power shows the papillary growth pattern with the fibrovascular cores lined by the epithelial cells. These epithelial cells classically show ground glass nuclei, as shown in the picture right here, nuclear groups, and nuclear pseudoinclusions. The follicular variant of papillary thyrocarcinoma shows exactly the same cytologic characteristics of classic papillary thyrocarcinoma. The colloid is described as having bubblegum appearance or dark or eosinophilic. Occasionally you can see multinucleated cells, and it has a similar prognosis as the classic variant. Microscopically you can see a solid growth with small follicular growth, higher power, the same follicular growth, and the cells show the classic intranuclear inclusions or orphan annii than the classic variant of papillary thyrocarcinoma. The microcarcinoma or papillary microcarcinoma has again the same cytologic characteristics of the papillary thyrocarcinoma, but it's an incidental finding found on thyroid glands that were resected for another cause like goiter, and then occasionally you can find these small papillary thyrocarcinomas that are usually less than 1 centimeter in diameter. The tall cell variant is again has the same cytology characteristics of papillary thyroid carcinoma, but the cells are described to be 2 to 3 times as tall as they are wide. These are larger tumors, and because of that they usually have necrosis, high mitotic activity, and usually have extrathyroidal extension at the time of presentation, and it has a more aggressive course compared to the classic variant. Columnar cell variant is a very rare type. It may resemble endometrial or colonic adenocarcinomas histologically. The nuclear features again the nuclear features of conventional papillary cell carcinoma are not well represented in these tumors, so don't expect to see the nuclear clearing of groups in these tumors. More often than not, you're thinking about endometrial or colonic adenocarcinoma or lung adenocarcinomas as well. These tumors can be TTF1 positive, so your differential diagnosis with lung cancer is usually something that you need to work out with more immunostains. The similar course is as the papillary thyroid carcinoma. The diffuse sclerosing variant of papillary thyroid carcinoma, it's more common in young people around 15 to 30 years old. Usually shows a diffuse bilateral thyroid involvement, and those papillary structures in a dilated lymphovascular space. These are usually seen. There's also extensive squamous metaplasia, fibrosis, and lymphocytes, and it's common to find lymph node and lung metastases, but still the course of the disease is not as bad as the clinical picture shows. Other variants worth mentioning are the solid cell variant, which is the most common in children. It shows the typical papillary thyroid carcinoma cytology and has vascular and extrathyroidal extension. The clear cell variant has been recently described and mainly shows clear cells with papillary architecture. These are TTF1 positive, and a cribriform modular variant, which is very rare, and it's associated with familial adenomatous polyposis syndrome and Gardner syndrome. Overall, papillary carcinomas are positive for thyroglobulin, low molecular weight cytokeratin, cytokeratin 19, TTF1, HBME. For the molecular testing, they are usually red, PTC1 or PTC3 positive. The good prognostic variants, so that's why one should spend time at the scope, is the encapsulated variant, meaning that the tumor has not disrupted the capsule, the microcarcinoma, and the follicular carcinoma, which has a RAS mutation. And the more aggressive variants of papillary thyroid carcinoma are the sclerosing, the tall cell, the columnar cell, and the heart cell carcinoma. Papillary carcinomas are known to have BRAF B600E mutation, but it's still controversial if this is associated with a poor prognosis. Red PTC oncogenes are more common in kids and in radiation-induced papillary thyroid carcinomas, and this activates the RAS-RAF-MEK pathway. More of this is going to be described and discussed during the molecular lectures. The follicular carcinoma is the second most common tumor, about 20% of thyroid tumors. It's most common in females and around 45 to 50 years old. Usually it presents like a single palpable mass, and it has a higher incidence in iodine deficient regions. It has a hematogenous spread, unlike the papillary thyroid carcinoma, as you remember, has more lymphatic spread. The malignancy of these tumors is determined by either vascular invasion or capsular invasion. There are also some histologic variants of this follicular carcinoma. We have the classic type, the oncocytic or heart cell type, the clear cell, and there's a minimally invasive and a widely invasive carcinoma depending on the capsular invasion. For follicular thyroid carcinoma, the capsular invasion is still a work in progress. Not many pathologists agree with this, but what's being reported or recommended by many of the societies is to follow this diagram. And this explains how you would consider capsular invasion as, for example, in part A, no, because you have only a pushing border, similar as B, but C, D, and E do represent capsular invasion. The difference between the C and D is that D may be transected and you can see only part of the invasion, and E you see a satellite nodule present in the lesion. Whether it's not yet or no in part F, G, and I, and J, those are the more controversial issues. In this example, you can see the follicular thyroid carcinoma that is extending into the capsule, and it's very important to find the capsule that is thickened compared to a thin capsule in other lesions. Since this is a very slow growing process, the capsule will be more prominent and thick, and this is where you have to orient your growth sections to a thick portion of the capsule. Higher power, you see the blunt looking follicular structures with the growth of these folliculars. The insular carcinoma is a poorly differentiated thyroid carcinoma, only tumor that shows iodine 131 uptake. It has a distinctive nesting or insular pattern of growth, which is reminiscent of the carcinoid or medullary carcinoma. Grossly, you'll find this firm brown cut surface, the presence of this what we call insular pattern of follicular cells forming little nests that are surrounded by fibrous tissue, delicate fibrous tissue. Higher power, you see that it doesn't show the classic papillary thyroid carcinoma histologic cytologic changes of internuclear inclusions or groups or anything like that. It's just a blunt growth of this follicular arrangement. The anaplastic carcinoma is a rare tumor. It comprises less than 5% of thyroid carcinomas. It's seen mostly in elderly people and with a slight female predominance. So far we haven't seen any papillary thyroid carcinoma that is male predominant, and that's a point that you should remember. These are rapidly expanding masses and with symptoms of regional invasion, and generally is a fatal disease within 1 year of presentation. Grossly, these are large, very firm and necrotic masses, and frequently replaces entire thyroid and extends to adjacent soft tissue and trachea and esophagus. The microscopic characteristics of an anaplastic cell proliferation, and you can see some squamous or giant cells or spindle cell appearance or sarcomatoid appearance. As you can see in the picture, the large, bizarre, atypical cells present here. Hard to say whether this is from thyroid or somewhere else, or immunohistochemical stains are usually guaranteed, and also the clinical presentation is very important to rule out other primaries. Hard-to-cell carcinoma is a typical brown tumor in the cut surface. Shows a follicular growth pattern, although solid or papillary patterns can also be seen, and you have to be aware of this presentation to rule out classic papillary thyroid carcinomas or any of its variants. It must show to be considered malignant, either vascular or capsular invasion. This is an example of hard-to-cell carcinoma. You see the follicular arrangement with extension into the capsule, which is very fibrotic and firm. Here we see the proliferation of these oncocytic type cells with ample pink eosinophilic cytoplasm, with these moderate to severe pleomorphism, and the extension of the proliferation into the capsule. Medullary carcinoma is a malignant tumor of thyroid C cells. CA and calcitonin are used as tumor markers in blood, and 5%. These represent about 5% of all thyroid malignancies. The sporadic presentation is about 80%, which is the most common, but there is an association with MEM 2A and 2B. These tumors may be associated with various ectopic hormone secretion syndromes, and nodules containing medullary thyroid carcinoma may be more ovoid than papillary thyroid carcinoma, and this is a radiologic impression that you can also use. There's also expression of red proto-oncogene. Typically, these tumors are composed of round cells with granular amphiphilic cytoplasm and round regular nuclei with coarse chromatin growing in nest or cell valence, separated by delicate vascular septa and hyalinized collagen. It's also common to see amyloid material, which you can easily highlight with Congo red stain, and these tumors can mimic any other type of thyroid carcinoma. Generally, these tumors are negative for thyroglobulin. Microscopically, you see the proliferation of malignant thyroid cells forming small follicular proliferations in a very bizarre growth pattern. In the background, there's all this pink eosinophilic material, which represents the amyloid. Higher power, you see that there's occasional follicular structures with some bizarre looking cells, mitotic figures, atypical mitotic figures, and these thin delicate structures, fibrovascular structures that surround these malignant and very atypical proliferation. Higher power to show the proliferation with eosinophilic cells and the pink amyloid deposition. So overall, the best prognostic variants to worst prognostic variants are papillary, followed by follicular, medullary, and the worst of all is the anaplastic. Finally, a few words on parathyroid gland. Basically, I just want you to remember three things in this parathyroid pathology. One is the parathyroid carcinoma, the parathyroid atypical adenoma, and the parathyroidmatosis. These are three important concepts, especially at the time of frozen section. So how do you differentiate an adenoma from carcinoma from parathyroidmatosis? Parathyroidmatosis is seen in patients that had a parathyroid resection, and the parathyroid tissue is seeded along the way, so then the proliferation creates these little pockets of parathyroid tissue, and they can be very atypical in appearance. So basically, the one feature that differentiates parathyroid carcinoma from all the other two is the capsular invasion of the tumor. Usually, the parathyroid carcinoma has thick fibrous trabeculae within the tumor. A typical adenoma can present, but is rare, and parathyroidmatosis is usually very rare. Trabecular pattern, parathyroid carcinoma presents with a trabecular pattern, where atypical adenomas and parathyroidmatosis not. They are most resemble the normal parathyroid tissue. The mitosis is usually greater in parathyroid carcinoma compared to the other two. A Ki67 may help. When you see a high Ki67 proliferation index, you can be more prone to call this parathyroid carcinoma. Thus, this is a nuclear pleomorphism is a soft criteria, because all endocrine tumors will have some neuroendocrine atypia. but parathyroid carcinoma will have larger ATPL compared to the other two lesions. Vascular invasion is sometimes present, and if it's present, it's very helpful, but you will not see it in all the parathyroid carcinomas, and you will never see it in atypical adenomas or parathyroidmatosis. Finally, lymph node invasion is a feature of carcinomas and not adenomas or parathyroidmatosis. This is an example of parathyroid adenoma where you see these well encapsulated and cellular homogeneous lesions with no adipose tissue. This is a fatless nodule, and the microfollicles sometimes can, these small microfollicles sometimes can resemble thyroid, and it's not uncommon to find them. These are particularly a hassle when you are doing frozen sections and you're called to see whether this represents parathyroid tissue or thyroid tissue, and you may be fooled if you think these microfollicles are thyroid. High power, you see this depolation of oxyphilic and chief cells in this delicate capillary network. And in high power, you see all these cells that they sometimes in touch preps cytologically look like lymphocytes. Sometimes immunohistochemical stains can be helpful if you have the question whether this is thyroid or parathyroid. So parathyroid tissue in cases of adenomas and carcinomas will be positive for parathyroid hormone, cytokeratin, cyclin D1 and RCC, and the most helpful thing is that parathyroid adenomas are negative for TTF1. So with this, I thank for your attention. Again, my name is Daniel Rosen, and this is a lecture for Baylor College of Medicine. Thank you.